in pursuit of health and wisdom. Sapio with Buck Joffrey.
Welcome back to Sapio with Buck Joffrey. This week we have a great guest. His name is Dr. Michael Mantz with Santa Barbara Integrative Psychiatry. Dr. Mantz, thanks for joining us.
Oh, my pleasure. Thank you for having me here today.
So the reason we're going to be talking, what we're going to be talking about today is related to psychedelics. But before we get that, tell us a little bit about yourself and how you got interested in, all this stuff in the first place.
Sure. Well, we can go back a little bit, and you could always curtail. But I always had a lot of illnesses when I was younger. I was very sickly, even as a young child, and then all the way into my teenage years. And even by age 16, I had an endoscopy and a colonoscopy, and because all these different problems I was having. Well, some people thought it was IBS, some people thought it was gastritis, all this other stuff. And so I was on 3 medications. I was put on Prevacid, a proton pump inhibitor. I was put on a kind of regulator of the stomach, Bentyl, and another medication. And I just felt like it helped with the symptoms, but I didn't feel that great.
Yeah.
And then by age 21, I'm 270 pounds, eating all this kind of garbage. And then finally, I was able to meet with the gentleman. I read a book called Eat to Live by Dr. Joel Fuhrman. And I started regulating my diet. And once I started eliminating things like dairy and things like soda, well, those 2 things alone, within the first month, I no longer needed my PPI. I didn't have GERD, I hadn't had it again. My whole system started to regulate, and I lost 65 pounds, and I got down to 205. And I was just wondering, like, why aren't many of the doctors telling us about these very simple lifestyle factors that we could do? I was able to get off all the medications. So I had a lot of distrust then for the Western model, but I always loved health. So I pursued more nutrition by studying under Dr. Fuhrman for a couple years. And so I learned a lot about that. And then I got into exercise, and I wound up becoming a personal trainer, which later, when I went into medical school, I was the personal trainer for the med students and everything to try to help them through that. And also I got actually so fit that I became a model, a sports model for a while.
Wow.
I have no doubt. I mean, I wasn't that great at it because I still, what's interesting from a psychological perspective, I mean, I had a lot of insecurity for being overweight.
Sure.
And what happens, you lose all the weight, but your brain still carries that image that you're still overweight. So I didn't have a lot of confidence going into there. And that's why I didn't get a lot of gigs. The agent that I had is like, you should be getting more gigs. What's going on? You have to be more confident in yourself, but it wouldn't, kick in. So, going through all of that, I went through then some psychotherapy, and then I went through, and then I started learning more about supplements, nutrition, and I went and did an herbal school for a while, and actually it was a home correspondence school, but then I did a month in Utah, in the mountains over there, and we were exploring all the herbs. I met with all these sort of famous herbalists, and I actually have a master's degree in herbal medicine. So I started actually treating people at that point, helping them out. Yeah. But I kept on getting, well, you're not a doctor. You're not a doctor. And I always loved science. I just haven't liked how the Western model was helping people with science. And in fact, they had a very myopic view on what health was. But I recognized I also wanted to have some of the rigor and discipline that comes from the Western model. So I decided to go back to college and get my prereqs so that I could go into medical school. And I started medical school late at age 29 at Pittsburgh University. And from there, as you're well aware, when you're in medical school, it's like drinking out of a fire hose of information.
Yep.
And if you don't, it's better to actually drink the Kool-Aid and believe everything you're given to. But you can imagine I'm now distrustful and I'm getting all this information. I'm like, some of this is bullshit. This is like this and that. And then I had so much cognitive dissonance and I didn't know at the time I was diagnosed later with ADHD. So I just had this proclivity to want caffeine or some stimulants to kind of get me into the zone so I could focus. So I started using my herbal knowledge and combining all these stimulatory herbs to help me. I didn't know I was self-medicating at the time. And also then I was using more because of that cognitive resistance, or creating more and more fatigue in the body. I wasn't sleeping well and all those other things. So eventually it led to a crash in the system, and my heart rate went through the roof, and I was in an emergency room I was studying for step 1 for my boards, and it was in March, and I never forget it. My heart rate, I was having some pre-signs But now this came on like full force and it wouldn't stop. So I went into the emergency room and they saw widening of the QRS, which is an ominous thing on EKG. They actually had the crash cart there ready.
Oh, wow.
They gave me some stuff and my heart rate for the next 36 hours was ranging anywhere from 220 down to 40. It was going through this wild thing. So I got, what I'll just call as a dysautonomia or dysregulation of that fight or flight, rest and digest system. And I was out of school for 16 months. And I almost didn't come back into school. But what happened was I was so anti-Western medicine. I was on the other side of it now, like too far.
Yeah.
And so I resisted any kind of medication at that point because I had this belief that if I took the medicine, there's no way I was going to get better. Obviously not the most healthiest belief in the world. But eventually, after about 6 months, I started going into a depression after all that stress. And I couldn't exercise, which I love to do. And without exercising, I would get really restless. And then eventually, when I couldn't move, because what my dysautonomia is that when I normally was at my resting heart rate at the time was around 40. When I would stand up, it would eventually at by the third or fourth minute be at 130. And it would be that discrepancy in there. It was like, for me, that's like sprinting.
Yeah.
And that's what it was like for 6 months.
Wow.
And I couldn't move at all. But eventually I did meet this really awesome EP doc, and he diagnosed me with POTS, it's called.
Electrophysiologist.
Exactly.
Yeah.
And he suggested a combination of carvedilol, beta blocker, and Zoloft, because he said actually Zoloft not only will be helpful for your mood, which is obviously now depressed,
right,
but it actually has some components where it actually impacts the serotonin receptors in the heart and helps stabilize the cardiac membrane. So it was used oftentimes in POTS, but I was like, no, I'm not going to do that. But eventually, I'm still not feeling so well, so I eventually started taking it. And I was also seeing then acupuncturists at the time, doing psychotherapy at the time, seeing some functional doctors at the time. So I got a deep education, very uncomfortable education, but it really seared into me a kind of an integrative approach to healing. So combining both the nutrition, exercise, supplements, and judicious use of medications and other kind of treatments, and how to combine those together. And so I was originally going into family medicine before all this happened. I just enjoyed the more sort of holistic, that was as holistic as Western medicine can get. But after having some really, really uncomfortable experiences with psychiatrists, I realized that area really needed help.
Sure.
And I thought that they had a lot of the kind of doctors we see on today that do a lot of the functional medicine. A lot of them were internal medicine doctors or family medicine doctors. But I felt like psychiatry in and of itself should also be integrative, and that there was a gap there that I wanted to fill. So I switched my, what I was focusing on, and I went into psychiatry, and then, and then from then on, I started developing into an integrative medicine practice and how to create a model in which I can work with people with longer sessions, not like the med checks that a lot of psychiatry, like 10, 15 minutes and you're out the door. But generally, most of my sessions are 50 minutes long when I'm doing my general psychiatric practice, and obviously even much longer when I'm doing ketamine sessions.
So right now, your practice, obviously we call it Santa Barbara Integrative Medicine. So you're integrating not only therapy with ketamine, as we were originally going to talk about psychedelics, but also with all these other herbs and that kind of thing. Is that an ongoing practice? Is that how you do things?
Absolutely. I've always been either when I'm cooking or when I'm working with patients, I love a little bit of this, a little bit of that, trying to find out what are the best combinations. Because once you understand the mechanism of action, the biochemistry and what's going on a particular issue that might be happening, whether it's depression, anxiety, then you can start looking at, all right, what are these different pathways and how can we potentially modulate these pathways? And oftentimes, if we can do so with the elements that our body has been known to have, not synthetic elements in general, this is a generalization. Oftentimes you can get it's usually a more gentle approach, but it's a more profound approach where you can kind of heal at the root cause level and not just suppress symptoms that often what most of our drugs do.
How did you get into, because I know now, I think we talked before about how your practice is about, 50% or more dealing with ketamine assisted psychotherapy. So how did you get interested in ketamine in the first place?
I had a colleague, one of the most brilliant psychiatrists I've ever met, true Renaissance man, Dr. Jeffrey Becker. He was in town, and we became friends because we just had that love of integrative functional medicine. And he said he'd been doing ketamine like in his practice for, I mean, well over. I think like 15 years now. And so he put me under his wing, offered to teach me, and that classic mentorship, apprenticeship kind of a arrangement. And he had me go through a couple of experiences, him leading it, and I'm going through the ketamine assisted experience so I can feel it from the other side. And then he had me then work with other doctors and other patients, underneath his guidance and tutelage. And so I learned from him, and he was very adamant that ketamine and psychotherapy need to go together if we really want to use it for all its benefits. So I learned mainly through him how that idea, which I would have probably always done anyway, because I've had my own fair share of psychedelic experiences even prior to that, when I was in my 20s and 30s and whatnot, experimenting, as we say.
Sure.
So I had a little fascination with that.
So tell me about, I think obviously there's some people who've had the experiences, but maybe you can kind of describe, what does it mean? I mean, what does it mean to be a psychedelic? What are you experiencing in that state? And maybe that's different for the different types of psychedelics, but maybe you could go general and then maybe talk a little specifically about ketamine, because that's the one really that, at least right now, is legally available for use. So tell us a little bit about that.
Sure. So, I mean, the term psychedelic itself comes psyche, mind, delian, meaning to manifest. So it's mind manifesting. It was actually coined in, I think, 1957 with correspondent Aldous Huxley and Humphrey Osmond, who was a psychiatrist. It was actually the psychiatrist who coined the term. And this sort of mind manifesting. I also like the term entheogen. Theos, the God within. These are substances that allow one to discover the God within themselves, which I think is a beautiful way of putting it. So ultimately, I mean, just going on a very broad stroke here, that any psychedelic is like a substance that, when taken, has a profound alteration in our normal states of consciousness, often creating very different experiences in our perceptions, in particular visual, auditory perceptions, but also psychologically in the normal ways that we think and feel and relate to the world. So I think those compounds that have these acute experiences and these very profound shifts in the way we experience itself, that's one of the ways how I would define psychedelics in a broad way.
Right. Talk about ketamine in particular. Maybe you can tell us a little bit about how ketamine works, and maybe some basic neurophysiology before getting into the ketamine part to explain how it might be working.
Sure. I'll first go, before we go into maybe a little more of the detail orientation. And you think about it, that ketamine was approved in 1970 for anesthesia, and it was one of the safest anesthetics, and that's why it was actually, they were able to use ketamine out in the field. It was used in the Vietnam War.
Right.
It's called the buddy drug.
Yeah.
I don't know if you knew that, but because they would carry the injections, and if the soldier got severely injured, in the past they would have to just give him morphine, but oftentimes they might cause respiratory depression and kill the soldier. But ketamine doesn't have that issue. It doesn't really impact the respiratory system. So they would inject ketamine instead during the Vietnam War and be able to help, give them immediate pain relief without the dangers that's carried with morphine. So it's a very interesting topic with ketamine.
Yeah, no, absolutely. And that actually is, important, because it's one of the reasons why it makes it safe to use in the office setting, right? Because ultimately, like what we know about ketamine, and when I was a surgical resident, mostly it was used, I don't know why in particular it was used on kids mostly, but the big advantage of it is, like you mentioned, with various other kinds of anesthetics, not only, are you paralyzed, but you're, not able to walk and talk and that kind of thing, but your breathing actually needs to be assisted as well. Whereas with ketamine, you do not have that kind of reaction. It's an anesthetic, but it's something that allows you to continue to breathe, and that presumably makes it a lot safer. But how, go on though, I didn't mean to interrupt.
Sure. So think about, if we were to take a full dose of ketamine you're going to lose consciousness.
Right.
Well, now let's just dial that intensity down a little bit. So now instead of going fully unconscious, you're going into this sort of twilight state. And in this twilight state, it changes the functionality of how the brain is firing, how it's relating to the world. And when that's all going on, it winds up creating an experience where, think of it more like you're almost going into like a kind of a twilight hypnotic like state in which you're very open, because as your consciousness is sort of dissociating from the body. It's a dissociative anesthetic. It's sort of separating itself. You're no longer then feeling a lot of your own body at that point, and oftentimes a lot of the uncomfortable emotions when we're treating like depression or anxiety, the heart of any emotion are the sensations that it occurs. I often say to people like who have anxiety, is like, well, with all your worried thoughts, it's like, oh, what's if this happens, or what if that happens? But let's say I could kind of take your body and make it completely relaxed. How long do you think those thoughts would actually last in your brain?
Right.
And I would state that they wouldn't last long at all. That the actual substrate of an emotion are these sensations in the body that drive us: the tightnesses, the uncomfortable feelings, the cold, clammy hands. So by creating this sort of dissociation effect, you're taking that person away from from their own sort of conditioned adversive reactivity, so that they can just have this open experience. And oftentimes a lot of people experience some euphoria because ketamine affects the opiate system, so you get some pain relief there. It's an indirect mu opioid agonist. So, and also on that side, it improves afterwards it reduces the tolerance of the opiate receptor, which is why we often now are using it in opiate addiction. And that's one. The other one is the main one is that we all say is that it's an antagonist or a blocker of a special receptor, a glutamate receptor called the Nmda receptor. And by blocking this receptor, it's a little complicated, but the way to kind of think about it, you have like these two glutamate, because there's many different glutamate receptors. So you have these other two glutamate receptors, and there's these GABA being the major inhibitory neurotransmitter in our brain. Often, as we popularly like to stimulate it with alcohol and benzos and whatnot, giving us that sort of calming, sedating, sort of just like out of it effect. But these GABA interneurons are at resting state active, and they're actively suppressing these two glutamate, sort of neurons from talking to each other.
And just to clarify, glutamate is generally excitatory.
Correct.
Right.
I like to just describe it as that, GABA and glutamate are the dominant receptors. We always talk about like serotonin or dopamine, but in terms of actual numbers in the brain, the dominant receptors are GABA and glutamate. I think of like glutamate is the yang and GABA is the yin. And these two we want in balance.
Yeah. Okay. So ketamine is essentially working on the Nmda receptor.
Correct.
Right.
Which are located on those inhibitory GABA interneurons. So when you block these NMD receptors, it inhibits these GABA interneurons, which we're acting like a brake, and so it takes the brake away from these other glutamate receptors. And then by taking away that brake, you get a glutamate surge.
Right.
And these class of receptors called the AMPA receptor.
In effect, then what you're doing is you're taking away the down, and you're amplifying the up with glutamate.
Yep. Because at resting, you're in a sort of braked state, and so by doing you're disengaging the brake, allowing it to naturally then open up and flow.
So the actual effects of ketamine, though, they're also dose dependent, right?
Yes.
You can go from low. You talked about dialing it up more and more. So just in the context, and on a lot of these things, I realize we don't really know the answer, like why it is. But do we have a sense of like why inhibiting the inhibitor and creating this positive excitatory amplification with the glutamate pathways, why that would result in the types of dissociative, I don't know if you want to call them benefits or, experience that people have. Why is that? And does that start pretty quickly? How much do you have to amp it up before you get to that dissociative? element?
Typically, we do it through what we call like 0.5 milligrams per kilogram of body weight. Will often produce a decent amount of dissociation in most subjects that we give. So for like a 200-pound person, we're looking at about 50 milligrams of ketamine to start to have these sort of dissociative effects. One might describe their state as starting to become dreamy-like, as if their body's becoming more numb, and that they just don't feel their body. But what's interesting is that then the person's conscious experience winds up expanding when that often happens. Like it liberates the person from their body. And often people who are depressed feel very much trapped in their body. So to have that freedom can be quite like liberating and euphoric. So the NMDA receptors, and they're still working this out. There's also some voltage gate. I think there's sodium channels that are located in the reticular thalamic activating system. What the kind of the bedrock that we used to call the reticular activating system area of where we feel conscious awareness. When we suppress that, people will go into a coma, or animals would go into a coma. So it seems to affect that area, along with what's called the periaqueductal gray, which is the PAG system. So these deep sort of areas in our brainstem that control sort of their general arousal of our body. So by starting to inhibit that, and then now you have a control gauge of how much you want to inhibit. Go all the way, you lose consciousness. By starting to dial up, you inhibit it just enough where you're not fully shut down, but you're in this now twilight state, and that gives us access to a lot of persons. Like we have this conscious mind experiences and our thoughts and emotions, but we have the unconscious aspects. The things that we hear from Freudian stuff. But there's a lot of evidence that shows that we have non-conscious thinking and non-conscious affects. So by dialing into these deeper twilight states, you're able to gain access to these areas that we normally don't have privy or access to, which then gives us access to a lot of our older emotions and thoughts, things that are underlying our actual conditioning on how we perceive and relate to the world. And many times when you're depressed or anxious, you're going to have a lot of maladaptive conditioning. So what we want to do is, the idea is making the unconscious conscious. You get it back on the workbench, and then have a corrective experience or a new kind of learning experience to take the old conditioning and upgrade it to your current level, from maladaptive to adaptive. And by doing that, and that's often we do repeated treatments and augment that with the psychotherapy, we can then really upgrade the sort of operating system from that, for how that person is relating and to the world at large.
Well, you talked a little bit about you used the words augmenting psychotherapy, right? When you describe how ketamine's working, bringing some of those inside things out and that kind of thing. When you add that with psychotherapy, is the net result that you see in patients maybe an acceleration of whatever outcome you're trying to achieve?
Absolutely. Again, it's not 100% like any tool is, but the studies that we do have are still, for ketamine assisted psychotherapy, a lot of them are like case series level of evidence at this particular point, where we often see now let's just subtract out the psychotherapy element, but ketamine itself, when done, usually most studies look at it at like 6 treatments done, oftentimes in between 3 and 6 weeks. On treatment-resistant depression, we're seeing significant reductions in depression scores, in about 70% is what is generally cited. And then when we started to add the psychotherapy element to it, a lot of the case series are seeing things close to 80, 90%, which of course, there are some increased confounders with those type of evidentiary collections. But I have seen in my own practice, and I've been doing private practice in 2015, and I started using ketamine mainly around 2020, 2021. And when it was like, honestly, the first couple of patients that I worked with, it was amazing to see the difference. Again, not with every patient.
Because you started out with them in a non-ketamine relationship. Correct. And then so you could literally see the slope of benefit.
Exactly. Like I had a couple of patients that I was doing psychotherapy with for over a year on a weekly basis, because I'm one of the few psychiatrists that actually still does psychotherapy with, pharmacotherapy. So I would see these and things that we were stuck on for like months on end, and all of a sudden, like I'll just kind of generalize it so I don't identify anyone, but we had this person who's going through trauma, that had a lot of childhood trauma and being picked on, and on the first session and first dose, all of a sudden the memories came back, but because he was feeling a little bit of euphoria and he wasn't really feeling much of his body, he's like, this is the first time, and he had processed a lot of this stuff, both with me and EMDR therapists and a bunch of other therapies he's gone through. He's like, and it's the first time I'm completely okay with it.
Yeah.
And it
So
was
what's
amazing.
interesting about what you're saying there is, so like, I don't remember those pathways all that much from med school. It's been a while. Even though I was a neurosurgeon, you're just cutting the stuff up, right?
Well, they're shoving it down your throat, so you're not going to digest it fully. You get it done for like a week, get the test done,
right.
Move on, right?
But glutamate, what I remember from the pathways is this whole concept of neurons that fire together, wire together,
Absolutely.
right? So basically meaning that if you can get some, I think that's a fancy way of saying that when you have certain activities and you start relating them together, almost like a Pavlovian thing, right? Where you start relating two completely different things together, and the next thing you know, your brain is seeing them as the same. So in this situation, you were talking about, him having a little bit of that euphoria, and then actually bringing those thoughts up during the euphoria.
Correct.
And to put those together made it okay, right? These things that were difficult to deal with before became things that you could deal with in a better way.
Absolutely. So the idea, going from a psychological perspective, we go from the unconscious, we bring it to the conscious awareness, and then the idea is it's now on the workbench. It can now be malleable. So when it's malleable, then we want to have what we call an emotional corrective experience. Which, so let's say you were like bullied when you were younger, and now we're bringing that in that context. And in that context, the person might actually relive the experience. Sometimes they can actually go where they actually think that I'm the bully in that particular experience when we're doing it in psychotherapy and get angry. But that's good, because then instead of me getting angry back, I'm actually holding the space and everything. And by doing so, the brain goes, wait a second, this is not happening the way it happened in the past. And so now it forces the brain to try to update what's going on and be able to create a new memory in that case.
Right.
And the idea of memory reconsolidation. So the memory, when we think about it, it becomes active and malleable. Then when we have a different experience, and when you're talking about the euphoria being added on to this sort of trauma experience, now it's like, well, wait a second, maybe it wasn't as bad as I thought it was. And maybe I am okay at this point. So then that gets sort of smushed into that older memory complex, and it gets and that changes it. And then it gets reconsolidated back into long-term memory and has a kind of an enduring impact on the person.
One of the things that you mentioning psychotherapy in combination with ketamine, how do you extricate what's doing what there? In other words, the ketamine itself probably has, making some changes in the brain, and then therefore it may, not be that dissimilar from what other medications are doing for people with psychological or psychiatric illness. How can you tell that it's not just ketamine that's doing it, that it's, I'm sure the psychotherapy is doing something, but I'm curious, like, have you thought about, like, how do you extricate that? Is there data showing that there is additional acceleration and benefit when you add psychotherapy to those ketamine patients?
There is, again, as you can imagine, it's hard to quantify. As you're saying, it's a difficult thing, and oftentimes too, there might be biases in how we reflect. Like we know they're taking the ketamine, so it's not blinded at that particular point. So it is very difficult, and that's actually a larger issue in the psychedelic arena as more psychedelics are coming down the pike. It's hard to separate out. How do you create a placebo? It's an ongoing question. That said, whether I will look at it in both ways. Let's go back to where I was working with a lot of these patients, sometimes psychotherapy for years, or they were seeing a psychotherapist for years, and I was doing mainly sort of a integrative, sort of psychiatric approach, but not full on psychotherapy. But then, you see how they're progressing. All of a sudden, you add ketamine to the mix, and all of a sudden, you see an inflection point and a lot of growth going on. So I think one could safely say that there's that point of inflection, the difference in the trend. Maybe the person's increasingly getting better, but all of a sudden the slope changes. One could then say, look at that. And if I were a researcher, maybe that would be one way you could extrapolate the slope that before and after, if we're looking at certain scales that would indicate a level of growth or progress. that's, I think, one way. So I've seen that myself, just seeing how when people are sort of just slowly eking, getting a little bit better, maybe getting a little worse, and then getting better, and all of a sudden, boom, they go into another level where they just feel a lot better. They're not needing. Oftentimes, we can reduce medications. Another good indication of what's going on, in that realms. But the difference between, it'd be a little trickier on my end. I wouldn't. Well, that's been my experience with like going from the psychotherapy element, then adding in the ketamine, and then I haven't done much where the ketamine alone. I've shadowed a couple people who've done this. Who that's all they do. They just give the ketamine and they have a sitter. And from the experiences that I've seen with them, a lot of the people they would get transiently better, but it just made them have to come back in again.
Right.
So it's creating them. They would have to come back in. And so they would get better, and then there's a regression back to the mean. Get better, regression back to mean. Maybe a little bit better than that, but not the same way. When looking at that, and then also inheriting patients who went to other clinics, that's all they do is just give the ketamine. Again, a lot of times similar reports of the same thing. I feel great. A lot of people who probably are watching this have done their own sort of psychedelic journeys of one sort, and then they have these amazing experiences. But then afterwards, there's this eventually, maybe a month, maybe 2 months later, once they're all peaceful, maybe they got back with their family and all, and then all of a sudden now irritability starts to kick back in. So there needs to be an added work element that creates, like as you were talking about before, in order for the neurons to wire together, the biggest engine driver of that is repetition and really developing new habits and new ways of relating. So if you don't have that reinforced afterward, what we call post-integration therapy, then you're likely going to just be dependent upon just keep hitting that again. And then oftentimes we'll then overuse it and create another problem.
I want to shift a little bit to this specific problem of clinical depression. So just a few things, done a number of shows on longevity and that kind of thing. And I think sometimes depression in general is underappreciated as a medical problem. Typically, the way that it seems to work is that depression and inflammation are intimately related. So systemic inflammation throughout the body, just in general, making all those diseases of inflammation much worse if you have depression. So for example, cardiovascular disease, other inflammatory diseases. I saw a statistic here that untreated depression results in decreased life expectancy by 5 years. That's not including suicide. So that's just huge amounts of inflammation. And so I think that this topic is such a big one. Let me ask you this. Let's just focusing specifically on depression. What percentage of the population do you think actually has what you'd call clinical depression?
I think because I've been actually looking at this data ever since COVID happened and lockdowns, because I was very concerned about how prolonged isolation would impact the brain. Just basic understanding of the social nature of our species, how it impacts us psychologically. I was extremely concerned about the psychological long-term effects of such isolation. And so I've been looking at that, and I think, I believe there was a Gallup poll in this year in 2023. I think they put it at around 18% in the United States currently have depression. And just to give you a number, if you recall, at 2017, we were at 13.5%. So we've gained well over like a 33% or more raise in depression from 2017 to 2023.
And that's diagnosed depression, right? I mean,
I believe so.
There's got to be. Certainly, I would imagine, just anecdotally.
Yeah,
that's
it would have
massively,
to be like 2 weeks of. It's not just I feel down because I lost my.
Well, meaning like it's underreported in general. I think there's a lot of depressed people who don't even know that what they have is a depression, and maybe
I think it's over 50%. They estimate well over 50% of people who have depression. I think it was 2/3 that they estimate don't seek out treatment or care at all.
And that leads to, I think, a really important question that just regarding depression. What is depression? Because I've tried to explain this to people because I think in our society, depression is kind of seen as it's different. It's seen different from other diseases, but I've seen people who've been put on medications who don't want to be on those medications. And they're told by their primary care physicians to, maybe you should try to get off of those or whatever. The way I think about it is like, people need to understand that this is a real disease. It's not, I'm having a bad day, right?
Yes.
That's not what depression is.
Not at all.
It's a true disease that, just like with a diabetic, you wouldn't say, just try it without insulin for a day. Maybe you'll feel just fine. You're not going to necessarily, do that with depression. So let's talk a little bit about depression, because it's also not just one set of symptoms.
Yeah.
There could be people who are listening or watching to this podcast who've got symptoms of depression. They had no idea they would categorize it as that. So maybe you could kind of break that down for us.
Yeah, I mean, like you're kind of hinting at the difficulties with a lot of our psychiatric diagnosis is that it often is a very heterogeneous group. There's a lot of different presentations. They probably have different but overlapping causality. So, the main symptoms, you remember SIG-E-CAPS back in the day, like sleep, dysregulations of sleep. Oftentimes, most commonly, people will start to wake up a little bit earlier than normal, what we call terminal insomnia, usually more than an hour, will start to really catch up on you after a while, especially those of us who are highly productive. And then, you're going through like decreased interest in things. So the things like if you're TV shows that you enjoy or hanging out with friends, and you're just feeling this sort of dullness inside as what's going on, in that way. So and then feelings of guilt often is a very common one. Guilt seems to be a very common feeling in that way. Decreases in energy and fatigue, concentration, just rolling through that. And then differences in appetite, though it could be overeating or undereating, and then a whole range of other kind of effects that we can have. So, and these are lasting, that they're debilitating. So one of the things that determines like the difference between like major depression and say someone who's just feeling some sort of basic, what we would say colloquial depression, is that it's impairing their ability to function.
Right.
They're starting to see it, they're making more mistakes. They're not able to get themselves going. And these symptoms have to, for a diagnosis, they have to last for at least 2 weeks and predominate most of the day. So they're not just having like, they're depressed one moment and then all of a sudden like, yay, it's like they're down.
Right.
You can feel that. But I also want to highlight though, that not all depression is pathological. That oftentimes if we're putting ourselves in certain environments that are not healthy for ourselves, that it's actually a natural response to our body to want to shut down. If it's like, if we're hyper stimulating it or anything like that, then the body has to conserve energy. And so a lot of times our depression responses, and I want to highlight this, are not necessarily pathological as well.
Right. But there is this, if you had to characterize whether depression itself is physiological or psychological, how do you describe, how would you, a little bit of both, right? But
I see it as a coin. It's two facets of the same coin, and we can take a look at. And the decision is that I'm going to work on both sides on there. But what are the levers based on that person's patient history is that I want to push first? If they're really like have what we call like a vegetative depression, like they barely can like listen to you at that particular point. If you were to tell them to do even basic, like, can you go and take out the garbage, they may not be able to do it. And so that in those deeper vegetative depression, where they're just sort of psychomotor retardation, they're not moving as quickly, you're literally moving slower than you normally do. At that stage, we have to use more biological interventions to improve the brain enough so that it's receptive to things like therapy, because their brain is so shut down that even you teach them something, they're not going to remember it. They won't come back, and they'll seem resistant. But the problem is they're very deep in that depression. So it depends on the severity too, as to what interventions we may have. It also depends on how they accumulated it. Like if it's mainly psychosocial, like they had a divorce, they all of a sudden they lost say money and then friends. We may not actually even call that an actual like depression and that sort. It's because their circumstances are having these issues. So we may want to look at, well, what's going on? Why are all these interpersonal relationships having all these problems here? So then we may want to focus a little bit more, and maybe they're not fully down in the dumps. So we support them biologically, but we also want to emphasize the psychological elements, the interpersonal dynamics, things like that. So it very much is a customized approach that needs to be taken because it's a heterogeneous issue.
When you hear people who are depressed who may not know that they're depressed, what are some of the words that they use? Like, for example, I just can't enjoy anything,
Yes.
right? Like that one, I think is probably one that people don't understand a lot of times is depression. It's not sadness, but almost the inability to feel.
Yes, that can
Right?
be for sure.
Right. That's it. But what other examples? Like I'm trying to I think for people,
Help others. Yeah.
help others try to understand whether they may be depressed.
Yeah, well, you'll start to see is that we have a natural negativity bias in general. It's to help us survive. And so that you miss a kind of a reproduction sort of opportunity or a food source. You're probably going to survive, but miss the saber-toothed tiger marking over there, and you're going to not be passing on your genes potentially in that case. So our brains were wired that way, but when we become depressed, that negativity bias it gets inflated. So we'll start to see, just much more just sort of highlighting only the negative or just the negative and very limited sort of denying anything that's positive. Like we could look at a depressed person and maybe we see a 50-50 day if we were objectively sort of watching them from a camera. But if asking them and they would say, yeah, I was depressed the whole day.
Yeah.
So there's this, when the brain gets a little more inflamed, as you're highlighting, it starts to lose its nuance, its discriminatory capacity. So it starts to overgeneralize. And you'll start to hear in terms like you brought up, like absolute terms like never, always, it's always going to be like this. I'm never going to get better. These absolute. So you start hearing yourself using more of these absolute terms, pause, because there might be something going on there.
One thing I always thought was kind of fascinating and never really, looked into it was, the idea of perseveration, right? Like ongoing, coming back to the same negative thoughts over and over again. And my neuro background, when I hear that, to me, it almost sounds like seizure activity.
You're absolutely right.
And so is there kind of a loop system sometimes in these depressive?
Absolutely. And that's the one that I tend to work with most, is that people who probably have more of an obsessive compulsive tendency.
Yeah.
And so they tend to think about, and that could be really good. You could be really smarter and do really
Get
well,
things
but
done.
now give more negative material to that. And all of a sudden the brain is trying to figure out problem solve in that realm, but it doesn't realize that it's using the software that actually created the problem in the first place. And that's why generally once we start to get that inflammatory cascade going, you're using an apparatus that's no longer helpful for you to actually use in that way. So you get caught in this sort of, as you say, sort of a thinking seizure, and that you're in this rumination pattern. And that's oftentimes located in the affective center in the limbic system. And because one of the things that our more evolved part of our brain, our cortex, one of its main jobs is to inhibit overactivity of this limbic system. And so there's this connection between, say, the prefrontal cortex and, say, the limbic system. And then oftentimes there's sleep dysregulation. That's one of the big factors that almost all depression people that ever treated have. So we see that after even 1 to 2 nights of not so great sleep, the connectivity between this limbic system and the PFC actually starts to decrease. So you're taking away some of this inhibitory break. So normally when we would sort of think about something, and maybe it's something that unpleasant, but we think about it for a little bit, but then eventually we're just like, we just let it go. But now imagine now you no longer have the break is not doing so well to actually inhibit that. And all of a sudden you're thinking about it, and then you're thinking about it. Now all of a sudden you're feeling, you get this sort of, what your body's trying to do is trying to problem solve. I want to get rid of this uncomfortable feeling.
Right.
How do I figure that out? Now you're thinking about it with inflammatory equipment, and it's not generating the solution. So you're getting more frustrated. So then your mood then goes even lower. And then of course you want to really then get out of that. So you keep using this strategy of problem solving with faulty equipment, and now you're stuck in a kind of a quicksand trap.
So how do pharmaceuticals undo some of that chemistry? I mean, again, I think there's way too much we could get into with specific drugs and the history, and they've come through MAO inhibitors and tricyclics and SSRIs. But fundamentally, what is like sort of the overriding theme of medical treatment? Like what do we know? Like do various medications seem to break those patterns or just get people to feel normal? I mean, they don't make people feel happy. They're not like,
Unless you
euphoric
become
drugs.
manic on it, but which can
Right.
happen.
What's that? But they don't make people, euphoric. They just try to restore some level of baseline, normal kind of, the way most people feel.
Sure.
How do they work?
Yeah, it's a great question. I think one of the main things, obviously, that we use are the SSRI class,
Yeah,
which
selective
often
serotonin reuptake inhibitors, right? And
Exactly.
that's like the
Prozac.
Prozacs, the ones that people probably hear about and probably are on the most.
Yeah, I think
right?
actually 1 out of every 8 people or something along those
Yeah.
lines will be on or use an SSRI sometime in their
Yeah.
life. So they're very well used a lot. But when they work, they oftentimes experientially, I'll go with that first, and then we could always plug it
Yeah.
in later. Is when I see it work, there's two main components that I see what happens. One is that it reduces the hypersensitivity within the system. Oftentimes people are becoming more hypersensitive to just
Yeah.
aversive stimuli, in particularly the emotional, the body sensations, their body. So they'll start to feel, that kind of turns that down, that hypersen, making it feel a little more comfortable in their own skin again. Now, we can go too far with that, and this often happens when we go in certain doses where the person actually starts to feel a little more sort of like numbed out, where they can't cry anymore. They often come, if they're, hey, I'm feeling a little bit better, I'm more calm, but I noticed I can't cry anymore, like, and that kind of, so oftentimes we have to
Yeah.
then make an adjustment on
Right.
that as well. And then the other aspect of it is that for, some people as well, it improves neuroplasticity in certain key areas of the brain, like the hippocampus, where we have like, memory formation and those kind of things. And then emotional processing too. In
Just to
relation
interrupt
the
you real
amygdala.
quick,
Sure.
neuroplasticity is a big one. So define neuroplasticity, what that is.
Sure. I'll just talk about it. That it's when we learn or we learn new things in the body, it's the way the brain adapts to new stimuli that it learns about, in which it actually changes the structure within itself. So either like we have the neurons will either grow new dendrites, which are sort of like the receivers, so they can hear other ones, so they may grow and branch out to other neurons. When we're talking about
Making
they
new
may connect.
connections.
Correct. And then also at the level of the synapse, where we have the primary receptors that we're looking to modulate, oftentimes like with the serotonin, they too will go through like synaptogenesis, like new synapses will grow, these kind of things, from dendritic growth to synapse growth, even axonal growth. And in rare cases, some neurogenesis in some areas of the brain too can hurt, one of those being the hippocampus as well. So there's the boost in neuroplasticity, and then, and that way. And there also is a reduction in inflammation.
Yeah.
When it works. That's why we started to see, blanking out on it. It was fluvoxamine was often considered for COVID. And one of its reasons why it actually showed positive effects helping with COVID is partly in part because one of the big issues was with COVID would set sort of what they used to call a cytokine storm.
Yeah.
It would reduce that inflammation, and it had that, and also an immunomodulatory effect, which we also see as well when they work.
So what percentage of the time does it seem like, between whatever therapy and these medications that we're talking about, SSRIs or whatever, how often or how successful is treatment with that for people?
I think I'll have to just dissociate psychotherapy from that component for now, because and just look at it from there's different citing reporting. Some people are even saying our SSRIs even better than placebos, and to SSRIs can help up to 70% of people, but gathering from all the literature and everything I've done, own clinical experiences, unfortunately, like to get any significant positive results, if I were to give an SSRI, like to anybody, because I don't give it as indiscriminately as a lot of doctors would, but I would say just listening to patients and everything, that maybe about a third might benefit, for a while. But I would say even less than that after 12 years. I think 12 months, there was like maybe, I think it's only 25% gets any kind of sustained significant reduction and or remission from symptoms. So that's why although they're generally safe, although there are issues with them, they definitely are not the most efficacious. In fact, a lot of our older antidepressants are more efficacious, but the reason why we went to the SSRIs is because they were often with not having these as tremendous side effects. Correct.
Yeah. So let's talk about ketamine as it relates to depression, right? Now, obviously, you're using that in your office. So with regard, you talked a little bit about this, but maybe remind us, like, what do you think in terms of depression itself?
Mm-hmm.
Um, what is ketamine doing?
Yeah. Well, on the biological level, when you're inhibiting those GABA interneurons and turning on these other glutamate, those AMPA receptors are dedicated towards learning.
Mm-hmm.
Learning and adaptation, and so that actually turns down a cascade effect, which will lead to something what's called brain-derived neurotropic factor,
Yeah,
BDNF, which you can think of it as brain fertilizer. It's a
Right.
major neurotrophin or a
Right.
growth factor that sets a cascade for this neuroplasticity to occur. So that's one of the components. So again, I think of depression, if we're just going to really just sort of overgeneralize it a little bit, and that is that most times people are having reduced growth factors in the brain, so their brain is more sluggish, less adaptable to the
Yeah.
environment, so that oftentimes they'll feel overwhelmed and they can't handle things.
Mhm.
So there's that component, and then the inflammatory component. So going back to the BDNF and all that ketamine does, we're now starting to help that and increase the growth factors of the brain, improve the neuroplasticity of the brain. So it's helping that big pillar. And then also ketamine has anti-inflammatory effects, again, through the sigma receptors and through some immunomodulatory things in which they're still working out how it's impacting those specifically, but it's improving and increase. So it's having both an anti-inflammatory effect and a positive neuroplastic effect. So those two big pillars, it's addressing the two big issues that often generate depression.
So inflammation can be something that you could treat fairly rapidly, but the neuroplasticity part of this seems like it would take a little bit longer. Yet one of the big roles of ketamine has been in basically treatment, the SSRI resistant depression, and that's where there's a lot of really promising data.
Yes,
right?
Exactly.
How quickly do people generally get those kinds of benefits? And maybe talk about the statistics on that, because I think this is a really promising and exciting area.
Yeah, it's tough to extrapolate because, like I was stating before, when they do just a treatment-resistant depression protocol, which is usually done, the ketamine is usually given IV, generally around 0.5 milligrams per kilogram, and oftentimes 6 treatment sessions, that they are seeing some significant results in reductions, like whether they're using a Beck depression inventory or whatever it is. In about 70% of the patients that they're working on, so a much higher result than what we're seeing from any of the antidepressants. So that's one of the key components on there. And I can just say, in my own sort of clinical work, is that if the person had like a depression, like let's say it's their first depression and they've had it for like a year, then oftentimes, I will start seeing results often within the second or third treatment. I'll start to see some significant, sometimes right off the bat, we'll see some results on that, but there will be oftentimes a regression back to the mean, as I described before. If a person's had it like multiple times and they've had it for a really long time and they have a lot of other behaviors in it, and it may take longer. In fact, the newer study was looking at that we should think about for people who have been sort of quote unquote seemingly resistant to ketamine therapy, that they found that in this other study that when they got to the 12th treatment, they were starting to convert a significant portion of these people that were considered resistant to ketamine to becoming now going into remission. So it may just require that these more intensified depressions that have been lasting a lot longer, which means it's going to grow tentacles and other maladaptive things. It creates a sort of a negative cascading effect, that it's going to require a little bit more oomph, a little more effort, more repetitions to go through to kind of undo a lot of these issues that are going on and leading to that. So again, that might take 6 sessions, and may now, as we see in this other literature, it may take up to 12 sessions. But often in my practice, when I brought people through like 6 sessions and combining that with psychotherapy, and again, that's a little bit conflated with also I add like supplements and whatnot, but we're seeing anywhere from 80 to 85%.
So now let's say you have somebody who's really been treatment resistant, meaning like basically they're taking their SSRIs and they're not, and they're not getting any benefit. The statistic, the data, I don't know. I don't know this literature very well, but I was trying to figure out like what percentage of people does ketamine appear to be able to help who are not getting help from these traditional medications, and it was somewhere like 50%, which is, I don't know if that's been your experience clinically, but that's pretty astounding, right? I mean, like it's
Absolutely.
50% of people who are not getting any benefit at all from SSRIs or whatever drugs you're being put on. I mean, half of them are or more are actually being treated.
Yeah.
Is that been your experience or even better?
I think it's even better. And, I think a lot of the issues with Western medicine is that it has difficulty handling the idea that psychedelics that's why set and setting is so important when using any kind of psychedelic. And I put ketamine in that category. So if a study can be doing where they're on like a kind of like a hospital room and they're getting just an IV drip and they're not really, using like music and all these other factors. So then they're just trying to squeeze out whatever physiological, and they're still getting benefits in that from doing those kind of studies. But when you really combine set and setting, and you really and you have persons like really kind of set intentions as to what they want, and kind of activating by doing that, you're activating a lot of the unconscious processes in the brain to kind of to be primed for the treatment. And when you do that, I mean, and people do follow through. So I'm a very big proponent that, like I said, ketamine's going to be, it's gonna give you eventually like a little bit more oomph. It's gonna get you to start doing new things. Now, if you keep repeating the things that you did to get into my clinic, well, guess what? You're not gonna get that much better. You might feel better for a while, but then you're gonna wind up needing it, again and again. But if you take this enhanced neuroplasticity and use the oomph that it gives you to create new habits, new patterns of relating, that's how you can really get and really shift these patterns and get very like long-term results. And I've had a lot of people after having really severe depression, oftentimes after 6 treatments, they're in full remission. Then often we look at, can we start lowering their medications at that point? Because oftentimes they're on concomitant medications. And then we might go from like once a week to once every other week, then to once every month. My goal is to eventually get them off. And a lot of people, when they really work, the work is really in between the sessions. And also that with any psychedelic, the work is afterwards and in between any psychedelics that you're maybe embarking on, that you don't get a free pass, but it is a very powerful push in the right direction. And it's important then to use that push to really create new habits for your life and shift it potentially permanently.
One more question about depression, and then I want to move on a little bit. But one of the benefits I think that a lot of people have had who've got really severe depression, who have the suicidal ideation, right? Like when they start really thinking seriously about suicide. And that's, by the way, that's a spectrum of depression. There's plenty of people with depression who never go in that direction at all. But there's a rapid reduction in suicidal ideation. Has that been your experience in your office setting?
Absolutely. Oftentimes, usually within the first or second treatment. That's the amazing thing about it. It's like an amazing thing, like where they literally, they're like, yeah, I noticed either, if not complete reduction of suicidal ideation, or simply just where they can just let it go. It's more just like sort of a whiff through, as opposed to when it's starting to increase its power, it becomes more intrusive, it lingers longer. So then the more that can linger, it can start to then turn from idea into action. So obviously, if we can start to dissociate that out, and that's what we start to see. It's amazing. That's one of the things that when I first started using ketamine, I had a couple patients. Those were the first ones I had who were having these intermittent suicidal ideation or every day, and just seeing such a profound reduction. It's like, it blows you away. I've never seen anything. And I've worked with herbs, I've worked with synthetics, I've seen all this stuff, and that just blows me away.
And then when you say that, though, one of the things that I get really curious about is the specific mechanism there, right? Like we talked about neuroplasticity, we talked about decreased inflammation. So, I mean, if you had to conjecture why that is, would you say it's like a significant decrease in inflammation, or whatever psychedelic experience itself, the dissociative experience itself? What do you think gives such an acute benefit in that setting?
Yeah, So I have a hypothesis on this. I haven't
Yeah.
heard people who
Sure.
describe it except for just the basic ways of the Nmda and everything like that. Though there's a neuroaffective scientist, Jaak Panksepp. He thought of these, and they're accepted by a lot of the neuroscience community. Is that there's 7 primary emotions that we all share, like rage, lust, and there's one. It's called the panic grief system, and I think it's important because a lot of doctors don't know this. And so the panic grief system is one emotional system at 2 different time points. We're a social species, and we were kind of, most of our evolution for our brain was when we were in sort of the tribes and with people. And so we depended upon each other in order to survive. If we were breaking off from the tribe, you were likely not going to survive. So when we break off the tribe, it activates our panic system. It's a distress vocalization to say, "Hey, I'm over here. Like, find me. I need to be found." But you're not going to continue to do that if you're not found, because you might alert a predator to your location. So then all of a sudden the panic turns into depression, or so it's a shutdown mechanism. So there's a shutdown mechanism that goes, and this is mediated by the opiate system in the brain in particular, and your brain will. And so what we're going through a lot of times, a lot of depression we're experiencing is, I believe, a hyperdesensitization of this panic grief system, which is modulated by the opiate system. So it actually increases an anti-opiate compound in our brain called dynorphin, which activates what I call the prey alert system, because it believes now you're separated from the tribe, you're likely to be prey. So it creates the dynorphin, which makes you more pain sensitive, because it wants to know what threats are going to be around there. I need to be more hyper aware and hyper arousal of all that. Now imagine that system was only meant to be acute, but now we make it chronic and stretch it out. I've been isolated, I'm feeling lonely. And I think that's the big key that drives suicide, because I think oftentimes if you're not going to be found, and then, like, say it's days and days, now it's like a month, and you're like, I'm definitely a goner, then oftentimes what we see in psychology is that a person is feeling so out of control, so like everything's so uncertain, that they want to gain control back. So oftentimes they'll feel like imminent doom, impending sense of doom. It's one of the common things we feel when we have a panic attack or anything like that. So it's like, well, why not I take the control back in my hands and kill myself before I get killed? I might as well, at least I know when it's going to happen if I do it to myself, rather than some animal doing it to me. So now imagine going into that suicidal issue and you're having these increased dynorphin levels. Well, one of the impacts of ketamine is that it is a indirect agonist to the mu opioid receptor, the same receptor that morphine and oxycodone. I actually believe that a lot of the isolation, fragmentation that's going on in our society is actually one of the main reasons why we have an opiate epidemic. It's self-medication from the lack of connection. So by activating in the psychedelics with ketamine, by activating the mu opioid receptor, you're reducing the hypersensitivity. And you generally, when we have a positive social connection, let's say we felt really good about our conversation here. We listened to each other. I listened to you. You listened. No one dominated the conversation, and we felt heard. You'll feel pretty good. You feel this sort of like, general, like, oh yeah, life is pretty good. That's opiate based mainly. So that's this sense of okayness, that happens, I think, is mainly modulated by that opiate system that the ketamine impacts, along with all the other benefits that also go. But I believe that's one of the core reasons why we see this immediate reduction in suicidal behavior, because you feel more, and then you feel okay, and you feel the sense, because the only way you would get that in the past is because you had a nice connection. So now I'm connected, so there's no reason to want to kill myself anymore, because I'm safe. And no reason to take that control over, because I'm not fearing a predator just coming after me at that particular point. That makes sense.
Makes sense. So we've been talking about depression, and I wanted to talk about that because, first of all, it's one of the major benefits of ketamine now is being able to treat people more effectively. And as we're going to see more psychedelics maybe and things like that come down the line pretty soon, hopefully there'll be more benefit. But you don't see, do you see psychedelics primarily, or ketamine in particular, a role for it in people who are not depressed, maybe don't have a clinical psychiatric illness, but who are also just trying to, say they're stuck. They are just feeling like lost in life, things like that. I mean, because I think that when you look at who's doing psychedelics and who's doing psilocybin and things like that, a lot of times it's people looking for, looking for inspiration and that kind of thing. What's your take on that? Like, do you do ketamine for people in those situations? And,
you have to be careful and really see
Yeah.
what their expectations are. But I do think there is a role here. Oftentimes Western medicine is more thought of like heroic medicine. We wait till the damage is fully on
Yeah.
and then do these very Herculean sort of treatments. But I'm more about like preventative.
Right.
So if a person's starting to feel a little bit lost, that might be one. And then there might be another thing that when he's feeling lost, or he or she, they may not be as affable when they're with their friends and family, and then they realize they're not connecting as much. So do we want to wait till they go and crash and burn, or do we say, hey, this person's coming in? Can we talk about like, hey, well, let's look at ways we can actually optimize your mind functioning. And also then getting to that too is also someone who like is at work and it's very highly competitive and they're really, really stressed out, perhaps using, ketamine or some of these other psychedelics could be beneficial. It would probably be way spaced in between, and we would want to then check on how that person is responding to it and how they're relating to it. And often I would want to check for like issues with like perfectionism, things like that, because we don't want to foster those kind of things, or just feelings of inadequacy if they don't get everything like really great in what they're doing. So we would want to check on those things. So oftentimes, if I'm working with a patient where I think it's kind of like on that boundary, we'll put our toe in the pool, see what's going on here. But I will also be working on those other elements if they start to uncover. And oftentimes it's feelings of inadequacy and feelings like that, because oftentimes that's why people who get into sort of the biohacking fields and all these other things who may start to then overdo it, which can then create a condition called orthorexia, where you're just so obsessed about everything needing to be perfect and I'm measuring this and doing all that, and that can be a big problem for a lot of people.
It's a growing problem.
It's a huge problem because, well, it's also showing that there's a generalized distrust of the body itself. And so that's what I'm working with when I'm working with like patients. I always bring them into their body when we're doing these sessions, because even though ketamine can be a dissociative, it's a dissociative acutely, but it's a reassociatively hours later. And so as they get better, they get more comfortable in their own skin. They don't feel like I have to do everything perfect because I'm okay inside. So I'm really looking, when I'm working with people on that front that might not be on like where they're fully having an issue like a disease like depression, I'm watching for those factors. But I do, to kind of answer it more shortly, yes, I do think there's a place there, but you would change the way you deliver it and how often you would.
Sure. So we will be right back.